Welcome back, everybody, to the Childbirth Attorney Podcast. I'm your host, Gina Mundy. Today, I have a great guest. Her name is Dr. Aria. She is awesome. So many letters behind her name. Super educated chick who is just beyond smart between her education, her experience, how she communicates, and whatnot. So this episode, we go into home birth and what you need to know to have a safe home birth. Right now, I know two people who we're about to do home birth, so this is a great episode for you. But, she also, the first part of the episode, we're kind of talking more about the hospital births, which she's very familiar with. And we also talk about the different types of midwives. She even told me stuff I did not realize. So it's a great episode. If you have a midwife involved in your labor and delivery, or if you're going to, this is definitely the episode for you, no matter if you are delivering at home or at the hospital. So I hope you enjoyed this episode and you get a lot out of it, because I know I did. The chick is absolutely brilliant. But the best way to figure out how your baby is doing is their heart rate. That pain, it changes the state of mind you're in. It is your wife who makes the decisions during childbirth. The Childbirth Attorney Podcast, hosted by Gina Mundy. Dr. Aria, how are you?
Well, thank you for having me. Hello.
Hey, yeah, thanks for coming on. And can you tell my audience a little bit about yourself?
Yes, so my name is Aria Pretlow. I am a newly minted doctor of nursing practice. So that is the highest level of education for nurses. We can get PhDs or what's called a DNP. One is research-based and one is more clinical application of the research, which is what I went for. I am an advanced practice registered nurse and a certified nurse midwife. I have postgraduate studies in psychiatric mental health nursing, which I apply a lot as a certified nurse midwife to perinatal mental health. And I'm an international board certified lactation consultant.
That's it?
Well, no.
No, there's more. No, I'm just kidding. No, she's just very, very qualified. So I love the part about midwife, home birth. Right now, I have two people, including my cousin who is due in August, doing a home birth. I have another home birth going next week, so I'll have to send the episode to them. But I also love your experience with home birth as a midwife.
Yeah.
So you did some of that. But real quick, so let's start from the literally like round one foundation. Like what's a midwife?
Yeah. So a midwife is a trained and educated person experienced in the, let's say, the clinical support, as well as emotional and psychological support of a gestating person. So usually, and I will say most of the time, we use very gendered language, and that's in part because of just how people's maybe their clientele are mostly presenting as cis hetero women, and so they call everybody women and mom. Also, currently, all the evidence, the studies are really on cis hetero people, and we don't know if we can apply all of those findings to a more diverse population. So because of all of that, we tend to just say women. So we support women throughout pregnancy, labor, and the postpartum. Depending on the midwife's training, if they are a nurse midwife, our scope is distinct in that we can also provide primary care from adolescence all the way through the lifespan. So, for example, I have supported teenagers, not because of pregnancy, but maybe difficult periods, bleeding what feels like excessively or too frequently or too painfully. Also just, like I want to be on the soccer team and they said that I need a physical, all the way through older women who are maybe trying to manage a new diagnosis of diabetes or thyroid problems. So we can do things besides just pregnancy. Midwives who are not nurse midwives are generally so the credentials can vary, licensed midwives in states where it's legal, which is not every state. And certified professional midwives is the certification, CPM, that that most programs lead to. Somehow you need to have either a certification that shows that you are appropriately trained and have passed a credentialing exam, and or a license, which also requires an exam. In the community setting, the certified professional midwife is not able to provide care outside of pregnancy, except in some areas, the scope will also include fertility. And so it could be that someone is trying to build their family or having difficulty and wanting some support there. Maybe they want to go ahead and get prenatal testing. They want to go ahead and see if there's anything that they need to optimize, let's say. And then the scope for the ongoing care of the neonate and the postpartum parent is, it varies slightly, but I want to say it, like in Washington, they can take care of the neonate. I believe it's through 2 weeks of life, because the idea is really to get people into pediatric care. And then the postpartum person, it's either 6 or 8 weeks, but also it varies by licensure. So it varies by state, which is one of the more challenging things in healthcare of being in the United States, is every state has its own rules, and we don't, just because you're licensed in one state doesn't mean you can practice in any other state.
Yeah, I got that problem too as an attorney.
Yeah, it's kind of
no reciprocity.
No.
So off the wall question.
I'm ready.
Are midwives, are they legal in Texas? My cousin's in Texas.
I don't know, but I know how to find out.
Okay. I know. I'm like,
I want to say yes. So let me say CNMs, certified nurse midwives, are legal in every state. So yes, for sure. And actually, no, yes, CPMs are as well, because I have some former colleagues who I attended the Bastyr University Master of Science in Midwifery program before I became a nurse. And I know at least one of them did her training in Texas. So there are some freestanding birth centers and practices there.
Okay. Well, thank you for explaining that.
Mm-hmm.
I remember getting into this field and I'm like, what's a midwife?
Midwives,
I know right now, currently in the practices they're everywhere.
Yeah. So. And please don't mistake us for doulas. We love doulas, but that is not the same thing.
Now, in terms of, real quick, doctor, you guys obviously are different than doctors. I mean,
and MDs. Yeah.
MDs. I know, like, no, you can't do the operative vaginal birth. Right. Even though I had a midwife steal a vacuum from a hospital and use it during a home birth. It did not go great. It's never great when I'm involved.
I'm going to guess not a nurse midwife. I hope.
I don't know. It was a while
because I feel like there's a little more like, we are kind of a certain breed. I think there's a lot of people who are willing to, in their view, do whatever it takes to support this person and their, not just their goals, but in some ways their dreams of how their birth will be. And they're like, it's not rocket science. I could use that. And if it means that she can have the birth that she wants, I will support her. I disagree with that. I want to support people in a safe and appropriate way. And there are 50 million reasons not to use a vacuum, period, but certainly not outside of a hospital. And also when a vacuum is needed and used appropriately, it can certainly improve outcomes. And people should have the option, but no, there are rules for reasons.
Yeah, I know it's a big role. So another thing too, midwives, doctors can do C-sections, not midwives. I know.
Some of us in the hospital, some of us will do the training to be a first assist, but you're correct. The thing to know about obstetrics is that all obstetricians are surgeons.
Yes.
Right. And I think that's an important thing that consumers don't always keep in mind. And we need surgeons. We need obstetricians. We need people who are very good at their craft, right? That's important. But also sometimes, so the analogy I tend to make as a parent is like, let's say you want to go on a date night, and probably, the 16-year-old who lives down the street and, let's say, has at least had some kind of experience in training, maybe as a sibling herself and or himself, and is like CPR trained, right? Great. That's probably good enough for your date night. You don't need a child psychologist. If you get a child psychologist to babysit for date night, you're going to come home and have a whole bunch of diagnoses for your 4-year-old. That, right? Because they know they have all of this wonderful training, and they're looking at things from that level, and not necessarily like, we're just here to like play Legos until mom and dad get home, right? Sometimes I think people want to use their highest level tool, and it's not, I disagree. I've worked with a lot of obstetricians, and they aren't, as a rule, right? They aren't looking for opportunities to operate. Everyone agrees that trying to prevent that first cesarean is critical to improving the future fertility and sex life and everything of that parent and the outcomes for the baby. And also, sometimes you need surgery, right?
Right.
So I think that, however, sometimes consumers are like, I just don't understand why there are so many cesareans. And I'm like, well, because most people go to the hospital, and that's where cesareans happen.
They happen, and they're managed by doctors who are surgeons. Boom.
Right? Like,
Midwives
if
are
that's
not surgeons.
that's a tool you have and you're good at it, and it's like, right? So CNMs, yes, we are not surgeons. We can do episiotomies, when it's indicated to, like, as a rescue situation. Nobody in the US, fingers crossed, we're not supposed to be. Nobody's just like cutting episiotomies because how else would a baby get out? Like, that's not a thing anymore. But shoulder dystocia, where you're making room to get your instruments in or your hands in to help free that shoulder, sometimes you have to make room. So there are indications, but they're very specific. And there's a point at which, of course, we are calling in an obstetric provider to assist with something like, sometimes they can put their hand in and help turn a baby that is malpositioned. And that is something most of us don't do with a frequency that we want to be the one doing that, right? But that way the parent can stay in our care, and we just have the obstetrician come in and like help out with the things they're really good at, because they do weird stuff like that.
Yeah.
So, it's like this, just different tools. Obviously, if somebody needs forceps, if we're calling somebody in because like they need an assisted delivery for some reason, then it's a collaboration in the hospital. Outside of the hospital, you don't, all you can collaborate with is another midwife, and their scope is the same as yours. And it does not include the use of a vacuum.
I know.
Wow.
So in the legal baby cases, when there's a midwife involved or there's an allegation against the midwife, you kind of just covered this a little bit, but do you know what it is? Like a typical allegation? One we see the most often. I know you're not an attorney that does baby cases, but I know how educated you are.
I feel like
I wonder. I mean, this is, what though? This is not stuff that they, people publish or that they teach you guys. I mean, when I'm out there talking and I wrote my book, people are like, why is this information just surfacing? I'm like, I don't think attorneys write books.
No, not usually.
I don't know what it
right?
is, but anyway, so I don't think this is something you're going to learn in school or whatever. I just didn't think.
Right.
I don't know if you know.
I think. I think there are people who either do too much outside of their scope, or they're not monitoring the baby properly. And if you're not monitoring the heart rate properly, even with intermittent auscultation, which the evidence does support its use, then, or you're, I don't know. What is it? What do they do?
Not getting the doctor involved fast enough.
So just not,
wait too
not
long.
making, not transferring.
They wait too long, even if they're hospital. They wait too long to get the doctor involved, and it's just the doctor. Yeah, they just wait too long. So how do you, I mean, when you're picking your midwife, I mean, what do you do? Ask them, what's your criteria? When are you going to get the doctor? Are you more conservative? Are you going to grab the doctor pretty quick? Are you going to do everything you can first? Like, as a patient, or a pregnant mom right now, if a midwife's managing them in the hospital, they may be like, what?
Yeah.
Because again, if their cases, most people know it's not good if I'm involved. So
Right.
it's a
Ooh.
permanent injury to baby or mom.
Yeah, that's why our tail
How
coverage
do
is so
you,
long.
talking to how do you get around that?
Yeah, I think so. Let's, if we can divide it up between the people who are having a midwife in a hospital. So you're having a CNM, you want a hospital birth, but you want midwifery care. Great. Okay. Because we are, as nurses, our approach is distinct from MDs. So that's a thing that is important to understand. We aren't facilitators of medicine. We are engaged in a nursing practice, which is an approach that is very much like, how is this experience affecting your whole self? Not just what are your symptoms and what can we do about it? And oh, is there a side effect? Okay, what can we do about that? But like, what can we get to the root of what is causing this issue and also tend to all the ways it's impacting your whole life, your family life, your home environment, whatever. So someone wants midwifery care. Okay. Patient-centered care, evidence-based, right? All the things that you think of, I hope, when you think of midwife. If I were interviewing a CNM, I would want to know what's your I would want to know their statistics, right? Like I want to know who their backup doctors are because I want to look into them personally. Like, okay, if your backup doctor is someone that I don't like their numbers, then maybe you're not the midwife for me just because the person you would call is not someone that I necessarily want involved in my treatment. Right. So there's a lot that could be involved and I come from a city, right? So I have lots of options. I might want to know like what is your transfer rate? What is like transfer to obstetric care rate? And that's going to be impacted by a lot of things. And it could be prenatal or it could be intrapartum. What's your relationship like with maternal fetal medicine? What kind of access do you have? How much, how long can I stay in your care if, let's say, I develop gestational diabetes and am having trouble managing it with diet alone, something like that.
Real quick, I mean, just for the audience
yes.
OBGYN versus MFM, real quick.
Oh, right.
I know that's very secondary to me, but I say MFM sometimes and they're like, did anyone refer you to an MFM? What's an MFM? I guess that's
right. So maternal fetal medicine is an obstetrician gynecologist who then specializes in more high-risk cases. So they don't do the baby catching. They consult and will oftentimes manage the intrapartum care. And so the people who are like high risk for any number of things, we know that this baby is impacted by the parent having a condition or the fetus has a condition or we have a low rate of growth. Like why is the fetus not growing at an appropriate rate? Small for gestational age. Well, by that time they're born, but yeah. So MFM is like, let's say we do something and let's say in your 20-week ultrasound, something looks weird for what it could be any number of things. Something is strange about the kidneys. And also your amniotic fluid is low. Is that because you're not making enough? Is that because the baby's not peeing enough? Is that because the baby is swallowing it and it doesn't come out? And so maternal fetal medicine is who's gonna let's look into that further.
Good, thank you. And of course, I don't know. Hopefully, we remember where you were when I interrupted you.
Yeah, I would want to know who are they collaborating with if I need some extra care and how long, like what is that relationship as far as can I still have midwifery as part of my team in the hospital or even just involved in the prenatal care. And those collaborative relationships are really important in all of healthcare, honestly, but who you work with, who you're not backup even, but just like who are you referring people to? Sometimes obstetric practices are collaborative, like they're built that way. And so they have right there in the practice certified nurse midwives who are taking care of all the low risk healthy people. And then anything that's like, it's not really low risk anymore, then they go to obstetric care. But that way the obstetricians can deal with the higher risk people, which is their bread and butter. And we can provide the labor support for the people who are just doing the thing, the physiologically normal thing, right? And nothing is currently in need of advanced care.
Yeah.
Does that make sense? Just like your family practice doc isn't the one who's going to take care of you if you get in the ICU, right? You're going to have a different level of care, right?
Right. So it's an in-hospital birth. They have they're looking at their midwives, or they're talking to them, making sure, I mean, is it appropriate to ask the midwife, like, hey, how often do you get the doctor, involved in labor?
Sure. And like, what are the things that might make, like, yeah, in the process of developing a rapport with your provider, these are reasonable questions, especially when we're talking about something as like the everyday miracle, right? Like however many thousands or hundreds of thousands, or I don't know what the number is, of babies are born every day, which would make it seem not miraculous. And yet every single one is like, holy cow, how do we do this?
Yeah, I know,
it's
right?
actually amazing, right? So it is reasonable to be like, everything could be totally fine, but it can pretty quickly, as you have seen in your work, I'm sure, it can pretty quickly become not fine at all. And what is your process for that?
Yep.
Right? That's totally reasonable.
Process? How often?
Yeah, they should be transparent about it.
Yeah. Now, right. And, all midwives are different. If it's, well, I'm now too old to have kids, but my kids, I would like them to have like a lower risk midwife who's like, no, just when in doubt, I'm going to grab the doctor and bring him in or whatnot.
Yeah.
All right, we got to get to home birth.
Okay.
We're like 20 minutes
we
deep into our conversation. I know we could just talk about everything. That's why your knowledge base is so awesome. I know you're coming back on this show. We'll figure out something else to talk about that's in your brain. So home birth, again, becoming very, very, very popular right now. What would you recommend? Because you used to do home births.
Yeah, and I had a home birth.
So, right. And I, people ask me a lot, Gina, what's up? Are you home birth or hospital birth? And I get the question, and I'm always like, listen, for me, I'm a huge advocate of all natural, spontaneous vaginal birth. Skip the drugs, skip the interventions as long as you can, or that's possible medically. And so I really like the home birth, obviously, because that is your all natural. That's you connecting with your baby, your body in an environment where you're comfortable.
Right.
However, I get a little bit nervous because, again, it's just what I do,
Yeah, sure. You see the bad things.
Care, there's no aftercare for baby, or, if something happens, you guys just are not at a hospital near the doctor, near, a surgeon if necessary or whatnot. So, I mean, I guess we can even start from square one. I mean, how does mom know if she's even a good candidate for a home birth?
Yeah. So, the number one thing to think about with out of hospital is the concept of healthy, low risk pregnancy. And many things are manageable with the support of modern medicine. And so they might seem not risky anymore, but in fact, they increase the risk of a poor outcome. And that could be anything from having labor start too early, having labor not want to start, having a baby that is, like if someone isn't able to manage their blood sugars for whatever reason, even if they're doing all of the things, that's a baby that can grow bigger than it otherwise would have, and therefore have difficulty managing its journey through the bony pelvis, basically, because we can't do anything about bones, right? So it has to be able to fit through her bony pelvis, and we can't know until it tries. So a lot of it is about risk. Every practice will have its own practice protocols based on standards of care. And there is a lot of sometimes heated debate about things as the kind of general health of our population at large changes, right? So more people have I know there's a lot of conversation around BMI and its value, but let's just say more people have a BMI of 30 or higher, and not because it's muscle, right? Like they have a body composition that is more adipose or fat tissue, which adipose tissue is metabolically active. It does things, right? And so there's a point at which we know statistically, based on the evidence, people with a higher BMI have higher risk pregnancies, right? And so it could be that your midwife is like, I would love to help you, but your BMI is higher than my practice protocol allows. Okay. It could be like, I would love to help you, but you already are a person living with diabetes. Doesn't matter, type 1 or type 2. That you're out of my scope. I would love to help you, but you already have hypertension. And yes, it's managed with meds. That doesn't mean you don't have hypertension. It means you have hypertension managed with meds.
Mad masks it.
Right? And so no, because your risk of preeclampsia and uterine abruption and placental abruption, no, thank you. It's no. Hemorrhage. Right?
You know what I learned the other day, by the way, and I, just remember where you're at right now.
Okay.
Baha Sabai on all his stuff on hypertension, preeclampsia. He writes everything for it. So he was telling me that the blood pressure medication, and this makes total sense, is really bad for the baby.
Yeah.
Because, baby is in uterus. Baby gets their oxygen through blood flow.
Yeah.
And now the blood pressure medication, is decreasing that flow? And then the decreasing oxygen and how that all plays out. But, I feel like in a lot of cases, that do involve hypertension, they're just eating it like candy. And I'm like, why are they? I don't know. And I know that it's bad for mom. I get it. But I'm like, he was very adamant on this. And I'm like, I never even thought about that.
But how does he square that with hypertension decreases placental blood flow? And so if we decrease placental blood flow, that decreases blood flow to the fetus and therefore oxygenation. So
I don't think is it a no-win situation?
I mean, that's why
the point of it was when you have this high blood pressure, you just got to keep a really close eye on baby. I mean, that was his punchline because listen, blood pressure and medication is not good for baby. I think though that ultimately, that really you got to take it, but then you got to keep a really close eye. But anyway,
which is what graduates them out of
all this time.
Right? That's what graduates them out of community birth options, right? Because there isn't a good that it needs to be monitored and supported in different ways, and it puts you at high risk for hemorrhage and all kinds of things during delivery and the immediate postpartum that you deserve, and your newborn deserves to have access to emergency care. Now, maybe, that's a big other thing. Are we talking about a home birth in the middle of some rural area that doesn't even have a regional hospital nearby and you have to get a helicopter? Are we talking about downtown Seattle where I could go to 5 different hospitals? Not 5, but
in pretty quick.
Right. Real fast. So other things that generally in the greater obstetric community, twins put people at higher risk. There's a number of things that it increases the risk for. It doesn't mean you can't have twins and be healthy, but the potential for complications is higher. A known breech. We all learn how to catch a breech baby, but and there is debate in the community. There's a lot of people that are like free breech, but generally speaking, it is a lost art to catch vaginal breech babies. And therefore, even if we allow that it might be some versions of breech, because not all breeches are the same kind of breech, even if we allow and accept that it is a variation of normal presentation and there's a wisdom of the fetus of why they want to come out that way, it doesn't mean that the people there have the skill set necessarily, or frankly, the equipment in case that becomes a fetus that has trouble, decreased oxygenation because cord entrapment or things that can happen, that it's going to need medical services as soon as it's born, beyond just what we're all trained to do.
What about VBAC?
Yeah, so
that one's more controversial.
Yeah,
I know a lot of VBAC moms who've delivered at home, and I mean, I'll hear the stories, like they had to go to like 5 or 6 doctors or midwives, to
find one.
Yeah. So I'm like, some people do it, but I would not recommend that as a childbirth attorney. But that's just
no, me neither. So I think the thing is people's understanding of the research varies depending on how much they're into geeking out with research, right? So a lot of people will look at a study and be like, oh, what, so some people are like, oh my God, it increases the risk of uterine rupture by whatever percent. You're like, yes, but it's apples and oranges, because everybody has a baseline risk of uterine rupture. And if we keep it just at the statistics, the statistics, even if you have a scar, especially if it's a lateral scar and not an up and down scar, it's still like it's definitely less than 2%. I think it's even less than 1%, right? So it's still a small percent, and everyone's perception of risk is different. So that's where it gets me, right? There are people who are like, but I'm more likely to end up with another cesarean if I go to the hospital. And there's definitely risks of that. But you both have risk of death if your uterus ruptures. Right. And they're even in a hospital, like the worst feeling is having to run to the OR. Right. Yeah, everybody's goal is to not have to run pushing that bed to the OR. And we can't run you to an OR out of the hospital. So even in the hospital, if someone has a VBAC, so here's the best case scenario is they have had a baby vaginally. And so we know that generally speaking, there's no abnormality in the bony pelvis. This is a quote unquote proven pelvis, right? They can get a baby out. And then they had a C-section, and it was probably for fetal intolerance, right? It wasn't because the baby got stuck. It wasn't anything with the mechanics. It was like, no, that for some reason that fetus was not tolerating labor well.
Probably on Pitocin, but go ahead.
Maybe. And so then they end up with a cesarean. And so now we have someone who has had both modes of delivery. Okay, but we are reassured by the knowledge that her pelvis has passed a baby through it before. That's great. Right? Because you're like, okay, so there's not because you can't know what's going on inside the pelvis. So even then, that is a person we do not use Pitocin on. We do not induce your labor. Best case scenario, you will at least please go into labor spontaneously so that they're not like, it's like 41 and 6. We're going to have to do something tomorrow. You're 42 weeks and that's standard of care. Ideally, you go into spontaneous labor, and then we are not augmenting that uterus because of the increased risk of uterine rupture in that scenario. So, so for me, knowing both sides and having worked with that in the hospital, I would like to encourage people with a VBAC personally and professionally to consider the ways in which they can have additional monitoring in the hospital that is not available to them in an out-of-hospital setting, that can help us keep track and see when, like, there are warning signs that we all learn, but when we use the continuous monitoring, which in that case is advised because of the risk, it buys a little time, and intermittent auscultation doesn't have that benefit. So I like a VBAC, midwife supported, but in a hospital setting for reasons.
Yeah, I agree with that. Okay, specifically because of what I've seen. All right, so mom chooses home birth, but let's say she's, she just chooses home birth. Now she's, I'm sure talk to the midwife or whoever about whether she's a good candidate. But the big question, how do you pick the right midwife, the good midwife? What's that criteria? What do you think? What should moms be thinking?
It's challenging because I think there's a lot of it that is an intellectual decision, and then there's a lot of it that's an emotional decision. And maybe those make the best decisions potentially.
Right.
But I think you have to balance. Certainly, it should be someone with whom you have a rapport that you feel like, oh, yeah, I want them in my house for potentially 24 or more hours, right?
Yeah.
Hanging out. Like they're whatever. I feel supported by them and like and like comforted and put at ease, and I believe them. So do they have the credentials that you want to see? Because not everybody has the credentials. Do they have the experience that is reassuring for you? Some people are like, I love a new midwife because they're fresh out of school and they have all of that, like they don't have bad habits yet, theoretically, right? I've except for maybe what they picked up from their clinical practice, but who knows? Some people are like, no, I want the grandma. I want the person who's like, I've got 500 babies and been in practice for 25 years or whatever. Some people are like, wow, I thought I would like you, but you remind me of someone in my life, and I don't want you to catch my baby. Other people are like, wow, you remind me of someone in my life and you need to be the one to catch my baby. So that's where the like emotion part. But I think the intellectual part is like, what are your stats? Right. So like, what is your transfer rate? What's your cesarean rate? Not because you're doing the cesareans, but like how frequently do you end up having to transfer someone? We can't always point to the midwife for transfers, right? Because if they're transferring, they're doing their job. So there's that, right?
Yeah.
You should be transferring people who no longer fit the criteria of normal low risk birth or normal low risk pregnancy. So it isn't wrong that they transfer. So then the question is, who do you transfer to? Like, who do you have good relationships with? How well do you know the various hospitals? Are we just going to go to the closest one, or are you going to like, do you know enough about different providers to like make phone calls and be like, oh, this person is on at that hospital and we have like great outcomes with them. And so we're going to transfer there. The thing to know about,
I like that.
Yeah, the thing to know about, most transfers are not because of emergencies. Most transfers are happening because the person has decided they don't want to be in this location anymore and they want the support that can be provided in the hospital. And most of the time it's because of fatigue or pain management, right? I can squeeze your hips till the cows come home, but I can't give you an epidural, right? I could give you saline injection in the sacrum to help with some lower back pain associated with like back labor, but I can't give you an epidural. I can't give you morphine. I can't, right? So all of which is fine unless you decide that that's now a change of plan. So given that there's time then for a transfer, right? Nothing is urgent. No one is suffering and no one is like showing us they're not tolerating labor well, either the parent or the fetus. Then it's like, no, really, who are your relationships with? In an emergency, you're just going to go wherever there's the emergency stuff, right? Just go to the closest thing as fast as you can. But most of the time it's not. So who do you go to? So that I can also have a sense of like, maybe that's where I want to take my childbirth education classes, because if that's the hospital we're going to go to, then I'll get a tour and I can see what the beds are like and kind of get a feel for how the unit feels to me. So people can get really in the weeds with their options. I would say interview multiple people. Everybody has some kind of meet the midwife, right? Because they're also agreeing to be hired by you. So you can fire your midwife, but your midwife can fire you. That's very, very important.
I've heard that.
And we will do it. We will do it when it's like, this is a person that doesn't either, like there's not the trust there for some reason. And I, as the provider, also have to trust you to not do what I say, but like, are you doing the things you said you would do to help you stay in my care? Or are you lying to me about those things? And now that is more likely to lead to challenges if we need to transfer. I need you to believe the words coming out of my mouth. My recommendation is that we transfer. Here is why. But I can't abandon care, and I can't force you into my car, your car, or EMS. I don't want to be stuck in a home birth situation, especially where all I can do is bear witness because I can't abandon care, and I also can't force you. And you're not listening to my professional recommendation. I don't want to be in that situation, right? So we also are assessing whether this client feels like a safe client for us.
Okay, real quick. So I actually had a midwife who does home births, and she reached out to me, and I get a lot of these questions these days. I think she heard me on a podcast or something. She wanted to know that if her home birth, laboring mom won't go to the hospital, she can't abandon care. What does she do? What's your answer?
Right.
Let me see if I got it right.
Cry.
Okay. I did not put that. Okay. Next.
Okay. What does she do? I mean, that's a professional situation. I hope to never, ever be in, right? I think that for me, I would try to walk this line between I don't want to bully anyone. I ultimately respect your autonomy. I also have to take into consideration, are you in your right mind? Right? Because people who are in pain can't give consent. Do they have a partner who can help make the decision? But in the end, the thing that you do is you call EMS so that they're there, but you also don't necessarily relinquish care. But as soon as she passes out, right? There are things where it's like, as soon as something happens, but like, why would you want to get to that point? As a client, like, why would you want to?
She was I love it. So my answer was,
you call them and they just stand there.
I call 911, and it's more of, now you have a third party involved, and 911 are trained to document. Yes. So they're going to get there. They're going to talk to both parties. And they're going to document. Number one, midwife would like to go transfer mom to hospital, interview mom. I'm not going. I'm having my baby at home. I don't care what my midwife says.
Yeah.
She's at least covered that way. She did make that recommendation. And this is a third party documenting this. It's not like the midwife can, write this down on a piece of paper and go mail it to herself or something, and then it comes back and she's like, the piece of paper, I mailed it to myself when it was happening. No.
That's valid.
No, I know. I don't even know why I thought of that one, but that's another way.
Yeah.
So that
you want other professional people there bearing witness and doing their charting. And also, who knows, maybe that's the thing that also then the client is like, okay,
maybe a third party.
You never know.
And EMS, I feel like they're trained to recommend hospital because just to escape liability. I mean, I don't know. We were calling 911 for a little bit for stupid stuff, and they would transfer. Well, after a couple $1,000 bills, I'm like, we'll walk. No, or not walk.
Well, also, like, there's a lot of stuff.
No, we're not going to the hospital. Like, we're not doing it. This is too much money. And I know you're doing it because you don't want to get sued if something happens. So I know, too, that they also liability, unless it's a complete fake call. But if you have any complaints, they're writing your concerns and complaints down. I mean, go. Yeah. They freak out when you say no, by the way.
Yeah. But that's what I would do. I would call back up.
All right. Yeah. So that's an interesting one. This is a weird one. Payment. Do midwives typically, do you do payment ahead of time? Or do you do half down? I'm only asking this because I had yesterday an episode, the bad doula episode, where I was heated and pissed off at the end of her story, because I am a huge, like I said, everybody knows this about me. I'm a huge advocate for doulas. I hope in the next 5 years, there's more doulas attending births, but like every profession, there's some bad ones. And I will, and then we did a little lesson, afterwards, or, whatnot. But one of the big things is like, she felt like she was stuck because she paid all her money up front, and she only interviewed one doula, by the way. Sorry, Brandy, for listening, because she's pregnant.
Yeah.
So too.
Oh, yeah.
but no, actually, you know what? She said all of this on the podcast. It's not even her and I information. But she was stuck. I mean, is that typical with midwives?
I mean, Well, first I want to say there's an interesting situation that we get into with finances where it's like, well, I paid for it. Now I just have to suck it up, even though I hate every minute of it. No,
Yeah, I know.
like maybe you're out the money, but now you're out the money and whatever from the experience being horrible, right? Like I'm a bit of like cut your losses, man. Just whatever. Like if you
Yeah.
can't recoup somehow any of it. So usually it depends on if it's a midwife that's taking insurance and you're paying with
Mm,
insurance or if it's cash pay. A lot of the times some amount will be due up front because it's kind of a retainer. And
yeah.
then either they have a payment plan because what happens in obstetric care specifically is what's it called? Global billing, right? So when everything is just normal in the course of care of a pregnancy, post pregnancy, during labor, and postpartum, the big bill comes at the end,
Hmm.
and especially for midwifery. So like this is all of your care, and it's supposed to be like 8-ish visits and whatever. It doesn't account for like, whoa, you were someone who had a 36-hour labor and I was there the whole time. I just made $1 an hour, right? Because we're adding in all the care that I
That's
provided before.
right. Yeah. I didn't think
So
about that.
yeah, whereas sometimes people, especially again, if it's cash pay, I don't, I think it's a business decision how they, if they do a payment plan or how they do it. But if it's insurance, the person who gets here's what happens. The actual birth itself is wrapped into the global billing, but if you transfer from your midwifery care into the hospital, it's whoever catches your baby gets the insurance payment for the birth, which is the bulk of the global care. So then the midwife has to go back and retroactively parse out each of the visits and like triage phone calls and whatever in
Mm.
order to try to get reimbursed, peanuts for all of the 10 months of care she has provided. I say she, most of us are she,
Yeah.
before you transferred and someone else caught your baby and got the like thousands, which for midwifery care is still the reimbursement is very low, certainly compared to a hospital birth. Even just a normal vaginal birth with no epidural, no nothing is still way more expensive in a hospital because you have to pay for being in the hospital.
Hmm.
Um,
So
so
cash
that's
pay, that was insurance. So cash pay is usually, is that up front?
I think I don't know. I think it depends
Yeah.
on what if
The
it depends on
insurance
the
on there.
provider. But
Hmm.
you can see where this is a conflict of interest for some midwives that will keep people in their care even when they really no longer fit the criteria because
Yeah.
otherwise they
That
don't get
crossed my
paid.
mind. So that makes it extremely important to pick a good midwife
Yeah.
because yesterday, when I was talking to Brandy about the bad doula, I'm like, what was the problem? Like, in the end, was she just stupid? Was she
Mm-hmm.
incompetent? Was she an idiot?
Mm-hmm.
What was wrong with her?
Right.
Money. She's like, no, she was just doing it for the money. Once I paid her, she was nothing, nothing. So she was
I
just doing it and I'm not saying the midwife's going to do it or
right.
whatnot, but I mean, you're putting a lot of time, a lot of effort in, and you're right. You get transferred, somebody else catches the baby. I mean,
Mm-hmm.
does even midwife, do they even go to the hospital typically with them and then get paid? Or does that point all funds start just going to the
No,
hospital?
if you are not a nurse midwife, you have no practice privileges in any hospital in America.
I know
And
that.
so they might transfer and become her doula. And then there might be like
Right.
some small charge for that, relatively speaking. But no, they're nothing from all of their time supporting in labor. Nothing is
Hmm.
reimbursable
I
to the
really
midwife.
like that point that you just made, like that whole point that we kind of came together on,
Important.
because that is
And
interesting.
And there's a weird thing happening in the doula world too, where there are a lot of places that I kind of, because I'm old school, I'm kind of like, why are you churning out doulas? It's like those yoga studios, and I'm a yoga therapist, so I'm not trying to diss yoga by any means, but the yoga studios who basically only are able to keep their doors open, not by the classes that they have, but by the teacher trainings that they have, even though there is no plan to hire any of the teachers they have trained because it's hundreds, if not thousands of dollars to do a teacher training. And it's like, $20 for a yoga class. So where you make your money that keeps your
Hmm.
boutique yoga studio in particular sustainable is by having workshops and teacher trainings, because that's like a year or more of people paying you for a big ticket item. So there are doula training things now that are like just pumping out doulas who maybe it's just like that seems like a good job and flexible hours, but being on call is never flexible hours, and also they get paid more than midwives. They have no clinical preparation. Like it's emotional and comfort support, right? Like giving you sips of water and squeezing your hips. I love a doula, but why do they get paid more than certified professional midwives to have less responsibility? They also don't have liability insurance because they're not doing anything clinical. I don't love that.
So I have really opened my eyes to doulas, paid attention. And you're right, when there's a lot of court, so because doulas are always on my radar, I swear things about doulas are constantly like sponsors and stuff like that constantly pop up, and it'll be like, be a doula. You're going to make great money. You can work remotely. You can do this. Like, I'm like, crap, I want to be a doula.
I know,
like,
right?
You know what I mean? So I can see where the draw, you know, the way that a lot of the companies who train doulas are, you know, the way they're pitching it, I'm like, this seems like a good gig. The problem is, you know, I think there were, you know, it's going to saturate the market, and it's going to saturate, it's going to, you know, there's going to be, you know, more not so qualified people coming in for the wrong reasons. I mean, being a doula to me was more of like personal gratification, not financial gratification. And that's doula, you know, you want, obviously, because you know, you listen to the last episode, you'll see why. But
like I want them to be able to make a living doing their work if that's, you know, if that's possible. But it is interesting when there's less responsibility but more pay.
I think this doula did nothing, and I think
was it one of those like thousands? Yeah.
It's like 1,100 or something. They met
amazing.
once 10 minutes left. They met once or twice.
Yeah.
She came to, she did not do early labor. She came right at the end.
What?
Yeah. No,
the whole point is to be there
for nothing, and the support. And then she wanted to do a birth plan. Okay, that's on the episode. I wouldn't even like rehash it out, but I'm so irritated. Okay, hold on. We got to go a couple more things.
Okay.
So with the midwife, they're trying to make sure you have a good midwife. Great things to think about already. Do you ask for references? I think references, and then same family. Have you done more than one home birth with a family? And I want that reference. Do you know what I mean?
Yeah.
I like that.
Yeah.
Bad outcomes. How many bad outcomes have you had? Meaning, you know, something.
I mean, it might be that they can't share very much because of HIPAA, right? But so, or if you know someone who is a nurse midwife or an obstetrician, and you're like, of the transfers you get, do you notice most of them are from one or two of the community midwives? Because I want to maybe think real hard if they're the midwife for me.
You
like transfers, really, not just like you get a lot of transfers, right? But like the ones that are really awful for everyone. Again, it might not be the midwife's fault. Like, I don't want to say every bad transfer is because the midwife is doing something wrong, but that it might be a part of someone's decision-making process is like, who can I ask to see what's happening when someone does transfer?
Yeah. Let's see. I mean, I don't know. I know if you ask your doula or midwife too, like, here's, you know, here's how much you're going to charge, or, you know, the layout, but are there extra charges?
That's important.
Got hit with extra charges, and she's like, no, she just didn't do it because she was so pissed. Extra charges or anything like that is something else that I had written down.
Yeah, like, is there care that you can provide that might be outside of the global charge? Right? Because let's say she develops a yeast infection. Well, that's not really prenatal care, but it doesn't mean your CPM couldn't necessarily like do the swab and send it to the lab and make recommendations about treatment that are not obviously because it's not in their scope to prescribe, but they might be like, here's home care you can do. That might be an E&M charge, like when we get into how medical appointments are charged. So that could be an evaluation and management visit and not part of your global care.
So the criteria for transferring from home to hospital? I know we've touched on it. Is it just really individualized on what may be going on with a certain client or patient?
So there are fetal indications and there are adult indications. So clearly anything where the fetus is not tolerating, the fetus is showing you that it is not down with this idea, right? Then that's a fetus that needs to be in the hospital for birth. It does. That we cannot mess around with that. So because we don't know when it will lose its reserve and no longer be able to compensate for whatever is going on. So that definitely needs to go. Then the big one is the adult. Are they like, this isn't what I thought it would be. It's going longer than I thought, or it's like I need pain management. I need something different. And then there's of course any indication of parent, like their blood pressure goes up. They are showing signs of preeclampsia. Like they start talking about they are like their vision is changing and they have a horrible headache. You're thinking, oh my God, is she going to have a stroke? Is she going to have a seizure? Because preeclampsia can go from someone is fine to they are so not fine really fast. So we're always monitoring for that. But that any indication of that, you want to be in the hospital. Any indication of infection. She was fine. Now she's got a fever. No, go be somewhere else. It could be a uterine infection and that's horrible and needs to be somewhere else. Certainly too much bleeding, right? So we can, in most states, well, I can't speak to each state's laws, but I know in Washington, we can use antihemorrhagics and everybody has, again, their practice protocol. But if I've needed to use an antihemorrhagic already, this is not normal. And so if it doesn't work quickly, I'm making the phone call to transfer as I give another antihemorrhagic and continue to manage that. And if we get it all under control, great. And she didn't lose so much that she might need like iron or blood transfusion or management of shock. Okay. But if there's too much bleeding and especially if it doesn't stop, but even if it does, they might still need care. If a repair is beyond your skill and or greater than a second degree and or goes anterior, nobody needs to be trying to do a repair around a clitoris at home. That deserves the work of someone who, right, or your urethra or like the labia has like go get people who do these things all the time and maybe do like more plastics work.
Definitely don't want to screw that up.
No. And of course, if they want to, that's always an indication.
Yeah. There you go.
And then there's all kinds of things of like labor progress, but yeah.
And then
in a nutshell, those are reasons.
I like it. And then, I mean, typically when there's a transfer to the hospital, is it like jump in the car or if it's, I assume if it's an emergency, it's 911 or is it always 911?
No, when someone is like, I just like, we've tried all the things and I have decided I want an epidural, right? Okay. Then that's not urgent. We don't need, as long as they can sit and buckle up, they can be driven to the hospital, right? Like they can't drive themselves, but they can be driven to the hospital, especially if it's not like birth is imminent. That's different, right? But they're like still 6 and, okay. The emergency ones, you should already have called 911 and then they're going to deal with that. And some emergencies, we will transfer with them because we're the ones holding things together, whatever that might be. Like if the cord tries to come out before the baby can, right? So then we have this whole situation that our hands are helping to keep the baby off their cord to keep them safe during transfer.
Intermittent monitoring.
Yeah.
The baby's heart rate, because obviously that's a good way to see how baby's doing during labor. Intermittent monitoring. How often should the midwife be doing this?
Oh, so there are clear protocols for that. And A1, which is the Professional Association for, I forget what the whole thing stands for, but obstetric and neonatal nurses, has a whole protocol for intermittent monitoring. And then the same basics are used for everybody else. So I don't have, it's not a thing I have memorized because I don't cut babies anymore.
Sure, just when you're, I think, interviewing the midwife, say, hey, you're just following the A1 protocol for intermittent monitoring. Perfect.
Yeah.
Yeah. Okay.
It varies by stage of labor.
They're pretty reasonable. I mean, I think I wrote about, I don't know if that's in my home birth chapter that I never published in my book, but I have a home birth,
like a whole other book.
It's for a book too.
Another thing for transfer, of course, if anybody needs any kind of resuscitation, they need to be transferred to the hospital for their post-resuscitation care. So if you are doing neonatal resuscitation, NRP, on a newborn, 911 should already be on their way. Right.
Okay.
So that is clearly an indication. Sometimes baby is born and there's something going on, anything irregular in their exam where you're like, baby's lungs aren't clearing. Baby's heart doesn't sound right. Baby's got anything that doesn't look right. They need to go have their own doctor. And those are located at the hospital for neonates. Like neonatologists are in the hospital. That's where you go.
I love that. This is such a great episode. I think dads need to listen to this episode because mom's going to be,
She's
doing
busy.
all the work. So dad, you're doing a home birth or I hope you listen to this episode. Well, you're obviously listening to it. So how about this? Moms, grandmas, anybody who's listening to this episode, if you know a dad who they're doing a home birth, he's doing a home birth with his wife. This is an important episode. So Dr. Aria, thank you so much for coming on. Can you tell my audience where they can find you?
Yes. Thank you for having me. So I have a website. It is AP Wellness Services, all one word, .com. And from there, you can find my professional LinkedIn, my Instagram, Facebook, and I have a newsletter called Aria's Office Hours. And I have a podcast. I will say all it is me reading my newsletter for people who don't want to read it. It's, but that's another option. So nothing is updated in the past couple months because I've been busy moving and finishing my doctorate. But all of that is in process to kind of get going again. So AP Wellness Services is where you can find me.
Awesome. And we will put that in the show notes.
Thank you.
So thanks again for coming on and sharing your amazing wisdom with the audience, especially the ones that are thinking home birth. So hopefully we make sure they have a safe home birth. So
yes,
everybody, thank you for tuning in to this episode of the Childbirth Attorney Podcast. I appreciate my audience. I appreciate that you guys have, taken the time to listen to the episode. So if you're on YouTube, make sure you subscribe. You can always find all my information, ginamundy.com. Shoot me an email, gm@ginamundy.com. It goes to my phone, Instagram, social media of choice. So please follow me if you want to learn more or keep up to date on what the childbirth attorney is doing. But hey, hope for us it's Saturday, so I'm gonna go enjoy the rest of my weekend, have some fun, enjoy my kiddos and family, and I hope you do too.